jun abatabale Davidson when you will get it. This is a box from the Davidson itself. And cranial diabetes, diabetes insipidus huन cranial diabetes insipidus, that is deficiency of arginine vasopressin. So arginine vasopressin deficiency भयो भने the patient may present with polyuria polydipsia. And so we have to exclude other causes of polyuria and polydipsias, and we have to go for water deprivation test or 5% saline infusion test. Similarly, to identify the hormone excess, we have to measure the random samples like serum prolactin random sample ma herna sakincha bhane. So we have to investigate for acromegaly, that is we have to assess for growth hormone after glucose tolerance test, or Cushing syndrome ko lagi hamle chai we have to go for 24-hour urinary free cortisol अथवा overnight dexamethasone suppression test. These all investigation will go through the chapters, and also then we have to establish the anatomy and diagnosis, like tumors haru cha bhane अथवा obstructive symptoms cha bhane we have to go for visual field testing अथवा peripheral visual testing or गर्न सकिन्छ. Then we have to image the pituitary and hypothalamus by imagings like MRI or CT scans of the pituitary gland itself. So in this picture you can see the pituitary gland. So this part is pituitary gland. This is this is a MRI. MRI showing the pituitary gland. Pituitary gland kasto देखिन्छ, posterior pituitary is hyper intense. So hyper intense यहाँनिर जुन सेतो देखिरहेको छ, this is posterior pituitary gland, but pituitary gland has intensity similar like the brain structures. So this is anterior pituitary. Just above it there is optic chiasma. This is pituitary stalk. यहाँनिर pituitary stalk छ. So this part is hypothalamus. And then you can see just in this region there is a part called third ventricles, and there is a sphenoid sinus. So this is a structure. This is a sagittal view. This is a axial view. So you can see same scenario here. It's a pituitary gland is here, pituitary stalk is here, and just above it optic chiasma on a success. So side by side, in both sides there is this internal carotid artery and also cavernous sinus. Now, if we see from the lateral skull X-ray, this part is sella torsica. This is anterior clinoid process, and this part is posterior clinoid process. So this is a normal sella torsica. We can even see in lateral phlegm of the skull. So when this is enlarged, you can see the sella torsica is structure, normal structure थियो, that architect is lost. So जुन deepening थियो यसमा, जुन deepening भन्नाले जुन depth थियो, the depth is changed and the size has been increased. That means there is some pituitary mass which we cannot see in X-ray though, but we can see the structure of the bone has been changed due to some pituitary mass inside this sella torsica. And when we see other structures, like this patient has enlarged structure of the bone with even prognathism, or the spacing of the teeth and oval thing, diploic space has been enlarged, so we can suspect this patient is a case of acromegaly due to pituitary macroadenoma. So there are some neuroophthalmologic tests like bedside confrontation test to assess the visual field, Goldman perimetry, Amsler grid, automated quantitative perimetries. So normally these type of defects अथवा जुन pituitary gland को जुन disease हरू छ, usually the management involves, if hormonal hypersecretion, then either go for surgery of the adenoma itself or medical management or radiotherapy. If hyposecretion, then we have to replace the drugs like glucocorticoids before thyroxine. Glucocorticoid replacement should be done always before the thyroxine replacement if there is both hormone deficiency. Sex steroids are if needed to replace, ovulation induction if there is given say fertilities, androgen, follow libido, and growth hormone replacement as needed. So there's a term called Sheehan's syndrome. Sheehan's syndrome is a pituitary ischemia and necrosis following postpartum hemorrhage and vascular collapse. When there is postpartum hemorrhage, vascular collapse, then the pituitary gland's blood supply will be compromised, which ultimately result in infarction of the pituitary gland, which ultimately leads to failure of lactation and breast involution, failure of menses to resume. So patient may present with features of hypopituitarism with time course. So pituitary apoplexy is another thing that is an emergency condition, which is spontaneous hemorrhagic infarction of existing pituitary tumor. So pituitary tumor भित्रै hemorrhage भयो र त्यसले गर्दा फेरि blood supply compromise भयो भने चाहिँ blood supply भयो भने the patient may present with sudden severe headache, visual impairment, ophthalmoplegia, meningismus, and altered consciousness. And the patient may present with acute pituitary failure with hypotension that may result as a rapid mental deterioration, and coma and death may ensue. So there's a term called empty cella syndrome when the patient may cella torsicama it may look black in MRI or pituitary MRI of the pituitary gland. That means subarachnoid space extends in cella torsica, partially filling it with cerebral spinal fluid. If partially filled partially empty cella syndrome or fully empty cella syndrome. These features may be due to congenital defects or acquired due to surgery, radiation. Patient may present with hypersecretion, hyposecretion, or normal secretion too. So we can see here is a posterior pituitary gland, but this part it looks black. यसको intensity र यो brain structure को intensity similar छैन, but यसको structure र third ventricle structure is similar. That means this structure अथवा sella turcica is filled with cerebrospinal fluid. So this is called empty cella syndrome. And their patient may also present with non-functioning pituitary tumors. Pituitary tumors हुँदैमा hyperfunction, hypofunction हुन पर्छ भन्ने छैन. 10% of pituitary tumors are incidentalomas. भने 10% of pituitary tumors that we go for MRI of the brain or MRI अथवा CT scan of the brain pituitary जे गरिन्छ त्यो routine other disease को लागि जुन गर्दा फेरि चाहिँ हामीले चाहिँ 10% peoples 10% population मा incidentalomas भेटाउन सकिन्छ. So the judgmental should be very accurate. अब यसले डिफेक्ट गरेको छ कि छैन, यसले कुनै प्रब्लम गरिरहेको छ छैन त्यसमा डिपेन्ड गर्छ बिफोर इभ्यालुएटिङ एन्ड ट्रिटमेन्ट अफ द डिजिज. सो जो नन फंक्शनिङ ट्युमर्सहरु छ, so if functioning then we have to go for surgery. If non functioning, if it is microadenoma we should observe. If it is macroadenoma, surgery, especially if there is mass effects. Then we go for acromegaly. So acromegaly what is the slide? So acromegaly is a disease due to growth hormone excess, due to growth hormone hypersecretion, hypersecreting pituitary adenoma. So 90% of them are macroadenoma, that is usually the size that is more than 1 centimeter, which may cause the compression of the related structures. So if there is optic nerve involvement, then visual field defects are una sakcha, then cranial nerves involvement, cranial nerve palsies and meningeal irritation like headache are una sakcha. So acromegaly ko features like acral enlargement are una sakcha, large fleshy thickening of soft tissues in hands and feet, enlargement of lips and nose, increase in shoe and brain size, facial wrinkles, heel pad thickening, coarsened body hair, And there might be musculoskeletal features like gigantism, prognathism, jaw malocclusion, arthralgia and arthritis, carpal tunnel syndrome, proximal myopathy, frontal bossing, skin dermatological feature like increased sweating, oily, coarse skin tax, and cardiovascular like there will be cardiac itself and the enlargement of the heart, cardiomyopathy, left ventricular hypertrophy, hypertension or सक्छ. There might be sleep disturbance and visceromegalies, endocrine metabolic effects like diabetes, diabetes or सक्छ, and menstrual abnormalities, galactorrhea, decreased libido, and hypertriglyceridemia, hypercalciuria. There are a lot of things, lot of features of acromegaly. So this picture depicts the features of acromegaly. Davidson के हो जस्तो छ भाइ. So अघि भनेकै कुराहरु हो सबै. So this is a picture अथवा this is a case of acromegaly. You can see the enlarged face with frontal bossing, prognathism, even skin taxहरू देखिन्छ कि जस्तो छ. And a great Khali, who is also a case of acromegaly. So diagnosis and investigations. So routine investigations त अरु कुनै प्रब्लमहरु छ कि छैन भनेर जस्तै डायबिटिसको लागि we go for oral glucose tolerance test and glycated hemoglobin. Similarly, we go for complete blood count, peripheral blood, urinary अथवा ECG echocardiography to see for the heart, chest X-ray, and then we say for serum calcium and other things. But the most important that how to diagnose if there is growth hormone excess or not, then we go for a specific test like insulin-like growth factor 1 analysis. Otherwise, if we don't have availability of insulin-like growth factor 1, then we go for OGTT suppressed growth hormone assay. So after giving 75 grams of glucose, we go for growth hormone assessment in 0 hour, 30 minutes, 1 hour, and test the. So if 1 hour, 2 hour growth hormone is less than 1 nanogram per ml by standard assays, then it is normal. If it is high, that is more than 1 nanogram per ml, then we suspect that there is growth hormone hypersecretion. So other like MRI pituitary to see for pituitary adenoma, and we see for X-rays where the bones of the hands or hands are enlarged. You can see the hands has enlarged, soft tissues. So there is osteoporosis of the bones. We see for a heel pad thickness around 18 centimeter in males and 21 centimeter in females. From the basic avenue, we can go for chest, even lateral skull X-rays. So in this MRI, you can see that there is a enlarged pituitary gland depicting a figure of 8. Okay, figure of 8. Your large pituitary gland is just moving upwards to compress optic chiasma and also the ventricles. So you can see here also there is large pituitary gland here also in axial views. So management is basically surgery. If surgery is not feasible, अथवा surgery मात्रै भएन भने we go for adding radiation therapies and medical therapies. Medical treatments like dopamine agonist, then somatostatin receptor inhibiting factors such as octreotide, lanreotide, dopamine agonists like bromocriptine, cabergoline, GH receptor, growth hormone receptor antagonists like pegvisomant. So these are the medical management, but the first line of treatment is surgery. Surgery is the choice always. Transsphenoidal surgery, either macroscopic or microscopic or laparoscopic. Then other treatment like treatment of comorbidities like hypertension, diabetes, अथवा osteoporosis हुन सक्छ, sleep disturbance, sleep abnormalities हुन सक्छ, cardiac heart failure हुन सक्छ. We have to treat all the other comorbidities and restore other hormone deficiencies. Sometimes acromegaly मात्रै भयो भने their pituitary adenoma हुन्छ, growth hormone hypersecretion हुन सक्छ, तर अरु hormone deficiencies हुन सक्छ like thyroid hormone deficiencies अथवा cortisol hormone deficiencies, LH deficiencies हरू छ भने we have to manage के भन्छ with replacements and follow up. and prevent biochemical recurrence or further recurrence ko लागि prevention गर्नु पर्यो. So there are other defects like hyperprolactinemia and prolactin secreting adenomas. So hyperprolactinemia and prolactin secreting adenomas. So we will talk about all of the hyperprolactinemia. Hyperprolactinemia ko karanharu धेरै छ. So one is causes like physiological like pregnancy, suckling, sleep, stress, coitus, exercise haru भनेको increase PRL production अथवा prolactin production नै हुने जस्तो like prolactin polycystic ovarian syndrome, pituitary adenoma, that is prolactin secreting pituitary adenoma, we call it prolactinoma. Then disconnection hyperprolactinoma means when there is a tumor in like in acromegaly, we have seen that there is large tumor inside the pituitary gland. When this pituitary tumor compress the pituitary pituitary stalk, then there के भन्छ जुन feature थियो dopamine जुन इनिबिटिङ फ्याक्टरहरु थियो त्यसलाई चाहिँ के गर्छ डोपामिनहरुलाई चाहिँ त्यहाँबाट चाहिँ जुन हाम्रो यो प्रोल्याक्टिन सेक्रेसनको हेल्प गर्छ जुन डोपामिन. सो डोपामिन ट्रान्सफर्मेसन अथवा ट्रान्सपोर्टेसन इज halted. Ultimately there will be secretion, hyper secretion of prolactin, which we call disconnection hyperprolactinemia. Then prolactin elimination ma reduction भयो भने like chronic kidney disease अथवा chronic liver disease हरुमा पनि prolactin high हुन सक्छ. Then hypothalamic PRL prolactin stimulation like primary hypothyroidism, that is related to thyrotropin releasing hormone, that is called TRH. Adrenal insufficiency हरु भयो भने prolactin high हुन सक्छ. Neurogenic like chest wall injury, breastfeeding, herpes zoster. There are a lot of drugs that cause hyperprolactinemia, especially we have to think of metoclopramide, domperidone, rizapine, other oral contraceptive pills, and others like tricyclic antidepressants and SSRIs, methyl dopa opiates, and even S2 antagonist. So there is a term called macroprolactinemia. I hope you will see yourself, and idiopathic पनि हुन सक्छ. So when prolactin rises more than 200, when prolactin rises more than 200 nanogram per, that is a strong indication of having a pituitary tumors, that is prolactin secreting pituitary adenoma. And PRL, if it is more than 400 nanogram, then exclusive that we suspect pituitary prolactinoma. And also we have to suspect some associations like MEN1 syndromes अथवा then this usually hyperprolactinemia or prolactin secreting pituitary adenomas may present with mass effects and presents with LHFSS defects like menstrual irregularity or amenorrhea, galactorrhea, infertility, decreased libido, osteoporosis, gynecomastia in male. So these are the features of hyperprolactinemia, and the treatment of choice is bromocriptine or cavaglorin. So first line of treatment is medical treatment in the case of prolactinoma, not like in acromegaly. Acromegaly the first line treatment is surgery, whereas the first line treatment in prolactinoma is medical treatment, that is bromocriptine or cavaglorin. Surgery if vision threatened, resistant to the dopamine agonist, or patient preference. So there are other tumors like ACTS secreting pituitary adenoma that we call Cushing disease, not Cushing syndrome here. Cushing disease haruko barema we will talk in the chapter of adrenals. And then TSS secreting adenoma अथवा TSS-OMA. This is a rare variety. TSS secreting adenoma. TSS secreting adenoma TSS will be high, FT3, FT4 itself will be high. So all the parameters will be high. Then there is a term called diabetes insipidus. That is a defects in posterior pituitary gland. Posterior pituitary gland original vasopressin अथवा ADS, which is secreted from the supraoptic nucleus or paraventricular nucleus of hypothalamus to posterior pituitary. यसमा कुनै defect भयो भने अथवा ADS release मा defect भयो भने there will be deficiency of ADS, which ultimately cause diabetes insipidus. So diabetes insipidus typically presents with polyuria, that is more than 3 liters of dilute urine in 24 hours. So how ADS is regulated, I'll not go through the physiology, but there is some ADS is increased by serum osmolality. When serum osmolality goes above the 280 milliosmol per liter, then the ADS is secreted. If there is thirst, baroreceptor, mechanoreceptors activations, like when the blood pressure falls increase, then ADS is regulated. Angiotensin 2, acetylcholine, catecholamines, and different hormones regulates the antidiuretic hormone. So antidiuretic hormone again decreased by osmolality if it is less than 270. Hypertension, catecholamine, atrial natriuretic peptide, brain natriuretic peptide, and some opioids. There are types of diabetes insipidus: primary, that is dipsogenic, usually psychogenic, and central, like cranial, peripheral, nephrogenic, and gestational. Central means cranial, which comes from the pituitary gland itself, whereas peripheral means it is the defect in the kidney. That is, in the kidney, the ADH is not responsive, whereas in central there is ADH is deficient. ADH is deficient, and gestational also during pregnancy, the patient may have polyuria. And primary means psychogenic, patient himself has psychological problems, or patient takes के भन्छ जुन पानी चाहिँ धेरै खाएको कारणले गर्दा फेरि उनी diabetes insipidus. So primary polydipsia, usually in a case of psychiatric patients like affective disorder, chronic schizophrenia, अथवा bipolar disorder. And central diabetes insipidus due to absent ADCS secretion, अघि नै भनिसकेँ मैले. So causes of diabetes insipidus, एकछिन ल म क्लासमा छु अहिले, क्लास लिँदैछु. So causes of diabetes insipidus include cranial causes, like when there is mass lesions in the hypothalamus or high stack lesions. अघि नै भने मैले जुन mass lesions हरु त्यही नै कुरा हो. Idiopathic or genetic defects like angiotensin vasopressin gene mutation अथवा Didmouard syndrome. Didmouard syndrome, like association of diabetes insipidus with diabetes mellitus, optic atrophy, deafness हुन सक्छ. So genetic defects, nephrogenic, like genetic defects in B2 receptors and aquaporin receptors, and metabolic abnormality like hypokalemia, hypocalcemia, drug therapy, lithium, demeclocycline, poisoning, heavy metals, chronic kidney disease like sickle cell anemia, inflammatory disease. These all causes diabetes insipidus. So while taking history in diabetes insipidus, they जुन कजहरुलाई चाहिँ हामीले चाहिँ we have to think of that cause and take the history. We have to take the input-output chart, consanguinity of the marriage, if there is any genetic defects, to suspect any genetic defects, family history of diabetes insipidus, and duration and progression. Diabetes mellitus, chronic kidney disease, छ कि छैन, ड्रग्सहरुको कुनै हिस्ट्री छ कि नै, like lithium, demeclocycline, psychiatric history हरु हुन छ कि छैन, if there is any features of mass effects like headache, visual problems, seizures हरु, if there is any defects of other hormonal deficiency like growth and puberty delay, कुनै history of features of head trauma, surgery हरु छ कि नै, fever, headache, and alter consciousness to suspect any infections, and tuberculosis, sarcoidosis को history to see another granulomatous अथवा infiltrative disease history. Signs and symptoms of primary disease itself: psychological evaluation, and IMA, optic atrophy, visual field defects, growth and puberty assessment, and dehydration. These are the things that we need to examine in a case of diabetes insipidus. So on investigations, we go for complete blood counts to see any infections अथवा tuberculosis related ESR आयो हुन सक्छ tuberculosis मा. Similarly, we have to see for to rule out kidney disease like creatinine and electrolytes if there is hypokalemia हरु हुन सक्छ. So hyperglycemia को लागि blood sugar गर्नु पर्यो, hypercalcemia, calcium, and then serum protein electrophoresis if we suspect multiple myeloma, which ultimately causes hypercalcemia. 24-hour urine volume हरु हेर्नु पर्यो हामीले चाहिँ if it is a case of polyuria or not. Urinary specific gravity in case of diabetes insipidus, true diabetes insipidus, then there would be specific gravity will be low in urine, that is almost less than 1.005. So plasma urine osmolarity, we have to measure plasma urine osmolarity. The osmolarity will decrease or increase. Diabetes insipidus ceremony, the plasma osmolarity will decrease. So we have to other tests like plasma antidiuretic hormone level, water deprivation test, 5% hypertrophic saline test, MRI pituitary, serum angiotensin converting enzyme in case of sarcoidosis, beta HCG to rule out pregnancy, and other like according to the disease. So how to do water deprivation test? Water deprivation test is confirmatory and to rule out peripheral and central diabetes insipidus. So your Davidson को box, so see the Davidson to establish a diagnosis of diabetes insipidus and differentiate between the cranial or nephrogenic causes. So we usually limit the intake during the morning, and ultimately we have to measure plasma osmolality. Plasma osmolality, if reaches more than 300 milliosmol per kg and urine osmolality falls, that is less than 600 milliosmol kg, then we can say that this patient has diabetes insipidus. Then we go for desmopressin administration. When we give desmopressin administration, if it improves, then it is a cranial diabetes. If it doesn't improve, then it is nephrogenic diabetes insipidus. So treatment of diabetes insipidus is usually we give desmopressin. In case of hypothalamic diabetes insipidus, central diabetes insipidus, and other drugs like chlorpromamide, carbamazine, clofeprid can be used. Similarly, in case of nephrogenic diabetes insipidus, we have to think of the cause like CKD or other connected cause or drugs like lithium sodium like hypokalemia, hypocalcemia. Then if there is no other cause, then we have to we can give hydrochlorothiazide, amiloride, indomethacin, or high doses of desmopressin and low salt diet. In case of primary polydipsia, we have to treat the primary psychiatric diseases. Then there are other diseases like I will not go through all of it, just see the book. I will just go through some causes only. Okay, so short stature patient lera auna sakcha if there is pituitary problem. Short stature may be due to growth hormonal deficiency, maybe due to growth hormone insensitivity, that is resistance to growth hormone like Laron syndrome, pygmyism हुन सक्छ. So growth hormone अर्को भनेको hypothyroidism patient may present with short stature when there is thyroid dysfunction before puberty like cretinism हुन सक्छ. Cushing syndrome हुन सक्छ, patient may present with short stature. Pseudo hypoparathyroidism, we may talk later in the parathyroid related disorders, and disorders of vitamin D metabolism that we call rickets or short stature लिएर आउन सक्छ. Poorly controlled diabetes mellitus, that we call Mouriac syndromes, and achondroplasia, hypochondroplasia. These are all causes of short stature, but some of the diseases are related to pituitary disorders. There are other non-endocrine causes of short statures like genetic, constitutional, familial हुन सक्छ, constitutional अथवा intrauterine growth retardation at small for gestational age, and syndromic short stature like Down syndrome, Turner syndrome, Noonan syndrome, Prader-Willi, Bardet-Biedl syndromes. Chronic diseases like congenital heart disease, asthma, malabsorption, thalassemia, renal tubular acidosis, and connective tissue disorders हुन सक्छ. Similarly, inborn errors of metabolisms like protein metabolism, glucose metabolism, or यो जुन चाहिँ तपाईहरुले पढ्नु भएकै होला, malnutritionहरु हुन सक्छ. So we have to evaluate through history, physical examination, evaluation, investigation, and treatment. Go through the book short stature को बारेमा डेभिडसन मा थोरै लेखेकै छ. Then other like tall stature भनेको के भन्छ अब. So how to define short stature, tall stature यो पनि जान्नु होला. Then there might be genetic causes of tall stature, familial हुन सक्छ, constitutional हुन सक्छ. Marfan syndrome, homocystinuria, Klinefelter syndrome, अथवा androgen insufficiency syndrome we call testicular feminization, and XYY or XYY karyotype, or call it Superman syndrome. So the के भन्छ causes of tall stature, go through the disease itself. सबै त गर्न Then other causes of tall stature like gigantism, acromegaly itself, thyrotoxicosis, precocious puberty are also causes of tall stature. During evaluation, we have to go through the history, physical exams, investigation, and treatment. अब यो पार्टहरु चाहिँ जुन चाहिँ मिस्ड भएको पार्टहरु हो, मैले यो पिट्युटरी डिफेक्ट्सहरु चाहिँ आई थिंक वी हैव टु टक एट द लास्ट, तर अगाडि नै पढेछौ हामीले, अगाडि नै क्लास रहेछ. सो अरु डिजिजहरु दैट इज रिलेटेड टु एन्डोक्राइनोलोजी, एउटा चाहिँ हर्सुटिजम, जुन चाहिँ म आई विल नट गो थ्रु द डिटेल, बट जस्ट कजहरु लाइक आइडियोपैथिक फेमिलियल हुन सक्छ, पोलिसिस्टिक ओवेरियन सिन्ड्रोम, कन्जेनिटल एड्रिनल हाइपरप्लेसिया, एक्सोजेनस एन्ड्रोजन एडमिनिस्ट्रेसन, एन्ड्रोजन सेक्रेटिङ ट्युमर or ovary or cortex, adrenal cortex, अथवा कुशिंग syndrome. These are all causes of hirsutism. So you also need to know somewhat of how to evaluate or what are the causes of hirsutism, that is excess hair in females. So other diseases like gynecomastia, please go through this. Gynecomastia causes like it may be a lot of causes, that is hypogonadism, androgen resistance syndromes, estrogen excess, the drug induced like simetrin, decoxing, spironolactone. So go for gynecomastia. There are term के अरे इन्फर्टिलिटी सब फर्टिलिटीको कजेसहरू छ, यो चाहिँ इट्स अ पार्ट अफ डेभिडसन. अब यति धेरै त चाहिँदैन तपाईलाई, जस्ट यु नीड टु नो समव्हाट अबाउट द कजेस अफ इन्फर्टिलिटी. And there are other diseases which I may not be talking at the end. तपाईहरुलाई त्यति चाहिँदैन, but just to know about the topics of endocrinology. एउटा चाहिँ we talk about the amenorrheas, pubertal disorders, that is delayed and precocious puberty, disorder of sex development, male looking like female अथवा female looks like male अथवा male female sex differentiate गर्न सकिरहेको छैन भने we call it disorders of sex development. Transgender endocrinology of pregnancy and fetal development, hormonal contraception and reproductive endocrinology, sexual dysfunction in men and women, obesity and disorder of lipid metabolism, neuroendocrine tumor and related disorders, osteoporosis, rickets, and osteomalacia. These all are the topics that is encompassed within the endocrinology. Maybe some part are multi-speciality topics. Just the rickets, osteomalacia may be related somewhere in orthopedics, rheumatological diseases too. So this is all about the pituitary disorders and other some part of the endocrine related disorders, which we may not talk at the end or later. So next class we will be talking about diabetes mellitus. I think I will go for diabetes mellitus, 2 classes of diabetes mellitus. So thank you for today. हामी अर्को क्लास फिजिकलै हुन्छ कि के हुन्छ सचिन?
अनलाइन हुन्छ सर.
हजुर
थ्योरी क्लास चाहिँ अनलाइनै हुन्छ.
थ्योरी चाहिँ अनलाइन हुन्छ सर, थर्ड इयर फोर्थ इयर फाइनल इयरले छ.
अनि प्र्याक्टिकल चाहिँ उसमै हुन्छ?
फिजिकली हुन्छ.
अनि थ्योरी चाहिँ फिजिकल नगर्नुको कारण?
खै सर, अब त्यही म्याथ धेरै म्याथमा होला एस्टेन्टहरु, 90 जना 100 जना हुन्छ नि त. अनि के रे क्लिनिकल पोस्टमा त 15-20 जना 30 जना ग्रुप हुन्छ, सब ग्रुप हुन्छ.
के भयो त 90 जना 100 जना भएर? एउटै त हो नि जसरी. 30 जना होस् कि 90 फरक केही छ र?
होइन सर.
ठीक छ then. Happy Saturday.
Thank you, sir. Bye-bye, sir.
Okay.